to, okay, let me just click that off. Thank you. Thank you very much for the opportunity to speak with you all today. And I do hope that we can have as much of a conversation as possible. I don't mind if people ask questions by the chat route, if that's probably the best. And I will rely on Kat or Maureen to sort of jump in and say, this question has come in. So please do ask questions. And Kat and Maureen, I don't mind if you interrupt me as I'm talking, if the question is specifically about what we're discussing at the moment. I don't mind. Okay. In terms of who I am, I might have met some of you before. I am a respiratory therapist, respiratory educator. And what I would say to anybody that I speak to who has underlying lung disease, whether we're talking about COPD, asthma, a mixture of asthma or COPD, somebody with interstitial lung disease, whether that's hypersensitivity pneumonitis or pulmonary fibrosis, one of the things that I think is very important for us to all understand is that shortness of breath is one of the universal symptoms that people will experience, whatever their lung disease. And if we're talking about COPD, for example, and contrasting it with interstitial lung disease, the symptom of breathlessness will be sometimes profoundly significant, life-altering, disabling, some might even say, certainly limiting in some way. And there may or may not be therapies which reverse that particular condition. So the definition of COPD is your lung function is always abnormal, despite all the therapies and the good things that you and your physician discuss. And with interstitial lung disease, we would say it's the same. There are therapies that are available, but there is really nothing that changes the course often of an interstitial lung disease. So breathlessness being universal then, or common to these conditions, people do need to understand the benefits of breath control. So people that have heard me talk before will realize that I'm going to talk about the 3 Ps of breath control: pursed lip breathing, pacing, and posture. And I cannot overemphasize the importance of these techniques to help reduce some of the breathlessness experience. And the reason I say this is that I do work in a very Western-based, pharmaceutically driven profession, and I don't say this to be dismissive of the wonderful medicines that are available through the pharma companies. However, I think our Western-based medicine is very prone to, here's a pill or here's something that will make your problem go away. And I think the challenge with COPD specifically, just as an example, is that you may get an inhaler that does help you, wonderful, but you're still going to be breathless because COPD cannot be rectified. It can't be reversed 100%. And so understanding what causes breathlessness and how to control breathing is really foundational. It's so important. It's also important to understand that there are many reasons for breathlessness. So all of us would understand that if I am not physically fit, I will be more breathless when I'm active. And we also understand that it's a very, very rock and hard place type of analogy or situation when perhaps we're breathless because of our COPD or lung disease, and then we become deconditioned because we're so breathless. So in no way, shape, or form am I doing finger wagging or pointing saying, you should be fitter, etc. What I'm saying is that we must acknowledge that breathlessness can be lung, breathless can be fitness, breathless can be weight, meaning I carry 40 extra pounds of weight around, I will be more breathless. Or I am underweight, I don't have enough muscle mass, I will be more breathless. And of course, we haven't even gotten into, do I have underlying cardiac disease, meaning other reasons to be breathless? Or the other one, which I think we sometimes forget, or people don't necessarily equate with breathlessness, that would be some sort of structural or mechanical problems such as kyphosis or scoliosis, meaning if I am profoundly stooped because of kyphosis, I will be more breathless when I walk because my lungs can't expand because the spine is taking up that space. The other reason would be pain. If somebody is walking along and you are sitting on a bench and you're looking at this individual walking past, you would be able to tell, oh my gosh, that person looks like they're in terrible pain. Look at them walking in that funny position. Well, anytime a person walks in a funny way because their hip is bothering them or their back is bothering them, it actually changes the mechanics of how they breathe. And so they will be more breathless. Now, if you don't have an underlying lung problem, people, they would ignore it. It wouldn't be a big deal. But if you've got COPD and you're deconditioned and you carry an extra 35 pounds and you've got a bad hip and you've got some scoliosis, my goodness, you've got 1, 2, 3, 4, 5, 6 different reasons that you could be more breathless. The reason I mention this is that BC Lung Foundation and a lot of other organizations that are in the respiratory sort of field, the health profession, recognized or thought were concerned that people with underlying lung disease due to COVID, because of the need to self-isolate due to public health orders, the need to self-isolate to protect oneself because of COVID, and because rec centers, exercise programs were all shut down for such a long time, that breathlessness in people with lung disease would go up, and that there would be an appropriate concern amongst people with respiratory conditions, particularly COPD. Oh my God, my COPD is worse. I'm so much more breathless now that I'm trying to get out and do my shopping. The reality is, for many people, their COPD, for example, didn't change at all. What really changed is their activity level went down, their conditioning went down, and their breathlessness went up when they started to get out more. And that's, again, that's important for people to understand, because a person could be thinking, oh my God, oh my God, oh my God, oh my God, my COPD must be that much worse now compared to 2 years ago. That may not be the case. So there's my sort of initial preamble that I just like to put out there to get people sort of thinking. If anybody has not muted their microphone, maybe you could do that, just so I don't hear any background coughs or snorts until you're invited to speak. Okay, so I did get some questions ahead of time, and they're really, really good ones. So I'm hoping that they will be applicable to at least some of you who are listening in. So if I may, I'm just going to read the basics of each question to give you some idea of what I'm commenting on. So when I was diagnosed with moderate COPD by a respiratory therapist 5 years ago, not quite right. Respiratory therapists do the test that supports the diagnosis that the physician then gives to you, just to be clear here, scope of practice. My results were sent to my family doctor, who gave me several inhalers to try out. No info was given to me about rehab. The inhaler I chose was not subsidized and very expensive, and I question why I wasn't referred to a respirologist. Wow, I mean, there's a whole bunch of questions there, and the question still goes on. We all understand, unfortunately, there is a huge problem with people, especially in Victoria, not having family doctors, and so people not getting the opportunity to understand what their test results mean. I can't help with that, other than I can say thank God for the Lung Foundation, that they're here to support you and support people like myself trying to support you. Many people who get breathing tests never actually have a conversation with the physician about the breathing tests. And sometimes that's because the physician may not be really quite sure how to interpret themselves. And I don't mean that as a criticism. Oh, bother. Sorry, I'll just turn that off. I don't mean that as a criticism of the physician, but the reality is that they have to know a lot of things about a lot of things, and they don't necessarily know the particular ins and outs of lung testing. Really, what we're looking for when we do a lung test, if we're thinking about COPD, is how well or not well do your lungs empty. So chronic obstructive pulmonary disease is about taking a big, big breath in, blowing out very, very forcefully. And if the lungs work well, the lungs should empty very rapidly. The lungs should be empty within 4 or 5 seconds. In fact, they typically would be empty before then. In COPD, though, the lungs are slow to empty. They don't empty very efficiently. And so it can take 6, 7, 8, 9, 10, 11, 12 seconds for the lung to empty. So it's how well the lung empties that gives an indication as to, is this consistent with COPD? And then it gives a way to classify the severity. The thing that's very important, though, to keep in mind with regards to severity of COPD is it doesn't all relate to what your number is. So people will often hear, oh, my FEV1, forced expiratory volume, that I blow out in the first second was 50 or 40 or 70. Yes, that number is important in the initial, is this a mild problem, a moderate problem, a severe problem, or a very severe problem? And we can get into the scaling of that a little bit later. However, it is important to understand that respirologists know that that number by itself is not a good predictor for how well that person is going to do. Meaning I can see people who have lung function of 40% and they're amazingly functional. They don't visit the hospital, they don't get sick very often at all. And so we would say they're at a low risk relative to another individual that might have lung function of 60%. They get frequent exacerbations or chest infections. They've had to be hospitalized once or twice, meaning respirologists now have a way to stratify the risk as to, we're more concerned about this person because of how sick they get and how often they get sick, as opposed to this person because this person has lower lung function, but they don't get sick very often. Now, the reason I give you this sort of preamble is to get to the question of, should I or should I not see a respirologist? So many people, meaning the vast majority of people who are diagnosed with COPD, probably don't need to see a respirologist. We would typically recommend a respirology referral if somebody has symptoms that seem well beyond what the lung function test suggests, or people have other complicating factors, meaning there's some uncertainty as to whether this is pure COPD, if there ever is such a thing. Is this something like asthma COPD overlap, where there's two things conspiring? Or are there other unusual characteristics of maybe a chest x-ray or a CT scan that were done, meaning other sort of comorbid conditions that might muddy the picture, so to speak. So not everybody does need to see a respirologist. Certainly, if a person is prescribed medication, therapy, and there is agreement that it doesn't quote unquote work, then it would be reasonable to say, okay, why do we think this particular therapy or treatment strategy that a physician recommended isn't working? Are there other factors at play? Would we consider respirology referral? Okay. Now, the question that is also included was, the inhaler I chose was not subsidized and very expensive. So here's where I will have to beat myself so you don't hear me about pharmacare. So, and Kat and Maureen and anybody that works for BC Lung Foundation knows that we get about pharmacare. And I don't mean to be too humorous or dismissive about this, but for the longest time, COPD medicines were unbelievably difficult to get for people. And it was only a respirologist could write the magic scribble, which would then force pharmacare to cover your inhalers. Now, there are some changes that have been made as of July of 2020, which have been hugely helpful. So, I mean, Kat and Maureen can send information out to people perhaps when we're done, but the basic way it works is that there's a family of medicines that are called LAMAs. So everything is going to be about acronyms, as I think we all know in medicine. Long-acting muscarinic antagonists, LAMA. So if you write that down and Google it, what you're going to get are two particular medicines. One is called Incruse, INCRUSE, and the other is called Spiriva, SPIRIVA. And you can, again, you can get this from Kat and Maureen after. But these two medicines are what we call 24-hour effective bronchodilators. They're at the forefront of really basic asthma, basic COPD therapy. So those ones are now freely available if you are registered for Fair Pharmacare to any individual diagnosed with COPD. In fact, what the government has done, which is sort of a good and a bad thing, they have recognized that spirometry, the blowing test, is necessary. It is essential for the accurate diagnosis of COPD. However, there's a dearth of locations available through BC to get spirometry done. So there might be a person who's in Fort Nelson and they say, well, how the heck am I supposed to get this test done? I'm not sure where the closest place would be. So the bottom line is both Incruse and Spiriva can be prescribed with no spirometry having been done to actually confirm the diagnosis of COPD, but they would be covered by fair pharmacare. The idea is they're muscle relaxers, bronchodilators, to try and keep the muscles from tightening around the breathing tubes. So nowadays, we would look at the standard starting inhaler list for people with COPD to be something like either Incruse or Spiriva, both covered, taken once a day, 24-hour effective, and then some sort of as needed inhaler. We might call it a reliever inhaler, a rescue inhaler. It would be either one of salbutamol, that's the blue spray. Perhaps it might be Atrovent, the white puffer with the green cap, or it could be something like Combivent, which is a combination of salbutamol and Atrovent. Okay. So all people with COPD would be advised to have an inhaler that they could take when they walk into Shoppers Drug Mart. Oh, I said their name. And you're exposed to all of the perfumes when you walk in the door. One of the craziest ideas I've ever seen for a pharmacy, but anyway. So anything that causes a sudden tightness, wheezing, sensation of breathlessness, and you think, oh my goodness, this exposure, I think, caused this. It's not anxiety or stress. It was something I was exposed to. Having a reliever or rescue inhaler at hand makes sense. Salbutamol, Atrovent, or Combivent. If a person had persistent breathlessness, despite using the breath techniques to the best of their ability, using any of the 3 rescue or reliever inhalers I mentioned, they continue to be breathless, it would then be either Incruse or Spiriva. Fully covered, standard fare pharmacare. So likely what happened in this particular story, it was Marilyn that asked the question, she was likely prescribed what we call a LAMA, meaning she was prescribed a combination of the LAMA, long-acting bronchodilator, and a LABA, and in a single inhaler. They're called combination inhaler, and they're expensive. In that they're not covered by standard pharmacare unless a respirologist writes the scribble, or you've been on either Incruse or Spiriva for up to 6 months, you are still breathless, you discuss it with your physician and say, you know, I've been on this bronchodilator, this once a day medicine, still doesn't help me as much as I think it should. Would you please put in a request to pharmacare for these LAMA-LABAs, these combination medicines, okay? And so a special authority request would be completed, etc. Now, there is a kicker with this one, and I don't want to get bogged, so I'm going to try and get all this technical stuff out of the way first. But you do need to have, or at least pharmacare says you're supposed to have, a breathing test done and lung function of less than 80% to qualify for this LAMA-LABA, okay? I think this is probably where I should leave it, because this LAMA-LABA, lung function less than, can often make people's heads explode. So what I would say, that the general message would be, yes, some medicines can only be prescribed by a respirologist to be fully covered. However, all of the inhaler medicines that are available for people with COPD, for example, or with asthma, are available, but there's a special authority request process that has to be followed, which can be cumbersome and difficult, etc. But certainly it is good news that the starter medicines for COPD, these LAMA medicines, there's 2 of them available, covered by standard pharmacare. Okay. Now, Marilyn goes on to then comment, is there some way that the respirologist can do the referrals necessary and prescribe the inhalers? No. So as a respiratory therapist, I'm not a physician. I do not prescribe medicine, nor can I refer you. So if you really feel, talking with your nurse practitioner or a physician, that your breathlessness, your story is too complicated for each of you to figure out together, and you think that referral to a respirologist would be in order, they would need to request that, okay? But just to be clear, the vast majority of people with COPD do not need respirology referral. So I'm not trying to dissuade you from referring, but I want to make sure you don't think that just because you have that, you should be getting referred, okay? I'm noticing some shortness of breath and some wheezing late in the day. Is this because of the different inhaler or a side effect of Omicron? I had a mild case of COVID in January. Well, the LAMA medicines, these once a day 24-hour bronchodilators, they are designed to give relief from chest tightness, wheeze, breathlessness, as best they can for a full 24-hour cycle. So what I would suggest is if you have a puffer that is either salbutamol, Atrovent, or Combivent, and that's all you have, you will need to use those more often through the day because each of them only lasts for about 4 to 6 hours. So the idea of these longer lasting medicines is to give more sustained symptom relief so that people don't have situations like what Marilyn is describing, okay? Can people have residual symptoms from Omicron or from COVID? Yeah, we're not talking long hauler really here with Marilyn, but yes, really bad viruses or colds can often leave very sustained, long-lasting symptoms. I can talk to people who got whooping cough, for example, and they have underlying asthma, and they can be quite miserable for more than 6 months. So, you know, some colds or flus or viruses are a little bit more irritating to the lungs. That is certainly true. There's been no retesting of my COPD in 5 years, which I find surprising. Has it improved, worsened, or remained the same? So in asthma, I know we're not talking about asthma, but in asthma, just to give a contrast, asthma is something that can go up and down according to allergies, seasonal change due to pollen, for example. Lung function can be very poor in asthma if a person is having an asthma attack, and then it improves dramatically when they're well again. So certainly in asthma, we would be more inclined to do a little bit more follow-up if a person was having symptoms that were all over the map, because we would say that does not indicate good control of asthma. With COPD, we understand that it is a progressive condition. It does get worse over time. Now, the difficulty is that you can't predict in who is necessarily going to be a slow decliner and who will be more rapid, other than the risk factors. So when we talked earlier, I mentioned that some people can have 40% lung function and they don't get significantly worse over time. They're remarkably stable. Other people who tend to get more frequent colds or chest infections, they need more courses of antibiotics or prednisone to treat these flare-ups. They do tend to have a more rapid decline in function and in quality of life and their abilities to do things. So the general approach is, if you feel that your COPD is being well managed, in that you're not having significant change in your breathlessness, in your ability to be active, in your ability to do the things that you would want, we would say, great, we do not need to do routine spirometry simply because you have COPD. So we usually reserve spirometry for situations where we collectively say, boy, oh boy, you know, Maureen's a lot more short of breath than we would think. I wonder why that would be. She did have COVID, and this has persisted for a good 6 or 7 months. Should we repeat spirometry? Meaning, do we think that the breathlessness is related to a change in lung function, or do we think that the breathlessness could be related to the fact that she was far less active for 4 months? And so maybe it's about her fitness and conditioning. So if you don't have more cough, more wheeze, more spit, more congestion, it's quote unquote just breathlessness, we're less likely to think that it's your COPD that's progressed. We're more likely to think that it's maybe fitness, for example. Okay. Now, I know this is pretty quick, and I do apologize, but I know there's other questions that are popping up, and I want to try and have conversations with people. The final one is there any correlation between COPD and sleep apnea? I was diagnosed with sleep apnea 4 years ago. Requested retesting this year, and it was a misdiagnosis. I do not have sleep apnea. Well, that's good. Yes, there is a correlation between COPD and sleep apnea. And by that, I don't mean if you've got one, you've got the other. What I do mean is if you have one and you have the other, there's an increased risk or concern around oxygen levels, particularly when people sleep. Okay. So, um, in an individual that has underlying lung disease like COPD, their ability to oxygenate or bring in oxygen at night when you're sleeping, you're lying flat, you're breathing less deeply, less regularly, your heart function is slowing down, which is normal. Your oxygen level may be a little bit lower than it should be when you're asleep because of COPD. If you then put sleep apnea, which is a pause in breathing at night because the throat up the upper airway is closing off. If you put sleep apnea on top of or in combination with COPD, that can be a more serious complication. So if they are related and there is sleep apnea on top of COPD, that would be more concerning than either one of them on their own. But in no way, shape, or form does this mean that if you have COPD, you're more likely to have sleep apnea. That's not the correlation we're talking about. Okay. Um, if I may, I will go along to the next question, and I'm also happy to get interrupted by Maureen, and there she goes.
Yeah, so Mark, I do see a couple questions in the chat actually just related to a lot of the things that you talked about just
Sure.
now. So one of it is, should a person with an asthma COPD overlap see a respirologist?
Good question. Not necessarily. Asthma COPD overlap is something that is, it is, okay. Asthma and COPD from a symptom perspective can be very similar. I can talk to people that have COPD, cough and spit. I can people who have asthma, cough and spit. Shortness of breath, wheezing, chest tightness, those symptoms can cross back and forwards. Not everybody with asthma has all symptoms. Not everybody with COPD has all symptoms. So the symptoms can cross over. So yes, it is extremely helpful, important to have a respirologist involved if the diagnosis is uncertain, meaning if there's a thought, so you have a breathing test done, you're 67 years of age, the test results are consistent with somebody that has COPD because even after you were given the blue salbutamol spray during testing, your lung function was abnormal in terms of how the lung empties. But you had a fairly big reaction to the blue salbutamol puffer. They might say, you know, this would be consistent with COPD. However, there may be an element of asthma because of the large reaction to salbutamol, for example. So what would be important is for that patient and that family doctor, if you're lucky enough to have one, to have that conversation to say, do I have symptoms back through my lifetime that would be consistent with having asthma, for example? Do I have a history of allergies? Did I have allergies or breathing problems as a child? Was I more prone to colds that would linger when I was young and have as a child? Did I have frequent bouts of bronchitis as a child? Because all of those things are abnormal. But if you're in your 60s, 70s, or 80s, nobody was diagnosing asthma at that time. They didn't even really understand what asthma was. So the history and the clinical story is really the most important factor here, not the lung test. The lung test confirms that there's an abnormality, but really it's the history of the individual. So if somebody said, I've had allergies all my life, I also smoked from the age of 20 to 40. So they have an element that would be consistent with COPD because their lung function's abnormal and they have a history of smoking, but they also have a history of seasonal changes due to allergies, problems as a kid with breathing. That makes the asthma COPD overlap diagnosis more likely. So certainly reviewing those sorts of histories and thinking about how your breathing has been over your lifetime, that would be an important part of sort of trying to figure out, is this likely asthma COPD overlap? And as I mentioned, if you and your family doctor say, there's just too many complicating stories, we're not sure. Yes, that's exactly why respirology would be consulted, because we would consult them when the diagnosis is uncertain. Because one of the big differences between asthma therapy and COPD therapy in simple terms is Asthma therapy would always have inhaled steroids as foundational treatment for asthma because it's a condition of inflammation of the breathing tubes, whereas in COPD, it would be much more bronchodilators, meaning muscle relaxers. You're not trying to reverse the injury that has taken place in pure COPD. You're simply trying to calm down the muscles that could be tightening around the breathing tubes. So the diagnosis is important for that reason, to make sure that you're on the appropriate types of therapies. A steroid containing inhaler for condition that includes asthma, usually just bronchodilators for a condition that would be more consistent with COPD.
All right. And you had also mentioned allergies. Clancy actually wanted to know, does allergy fit in with asthma or with COPD?
Well, I mean, it can fit in with both, but it's more common with asthma in the sense that asthma, allergies, and eczema, or sort of the triumvirate of how our immune system can display its displeasure with living things that are in the environment. So, we are not allergic to perfume, for example. Perfume is an irritant. So if we get bothered by a perfume when we walk through, yes, I'm going to pick on Shoppers Drug Mart again. If we walk into a Shoppers Drug Mart to get to our medicines at the back of the pharmacy, we might be bothered by all the perfumes or the colognes at the front of the store. We're not allergic to that, but it's an irritant because it's a chemical. So you can be irritated by that and have asthma. You can be irritated by that and have COPD. However, if we're looking at things like dogs, cats, mold, house dust mites, things like that, those are true allergies where our immune system recognizes this foreign substance and says, oh my God, this is a foreign substance. I'm going to create inflammation, itching and scratching and watery eyes, stuffy congestion in the nose, and maybe cough, wheeze, or tightness in the chest. So allergies are very common in asthma. In fact, most people with asthma have allergies. Now, there are other variations of asthma where allergies aren't a problem. If you look at COPD, it becomes a bit trickier sometimes to figure out. So, would we say that some people can have asthma and COPD at the same time? Asthma COPD overlap? For sure. We've just been discussing that. And in many people with asthma, they have allergies. So, yes, people with COPD can have allergies. It's also true to recognize that when people have COPD, their airways are more irritated to just about everything that's in the air. So I talk to lots of people who have COPD and they'll say, I can't believe how I feel like a weather station. I used to sort of, laugh and joke with my neighbor Bob, because Bob has arthritis and he could always tell me when the weather was going to change. Now I know that I have COPD. I can tell the same thing. My breathing is bad when it's cold and damp, and it's good when it's moderate and relatively warm. It's not very good when it's windy. I really don't like it when it's super cold. So the reality is temperature, barometric pressure, humidity, those are all things that can affect people with COPD. So none of those are allergies, but they're irritants. So if you look at, I was just out for a walk a couple of weeks ago, or last week, I guess it was, and I thought that I was seeing smoke coming from somebody's house onto the street. And then I realized it was pollen being blown out of the trees. It was just clouds of it. So if a person has COPD and they're breathing in clouds of tiny particulate pollen, that will be irritating to them. Now, whether it's a true allergic response and it's driving an immune reaction, it's still going to make them probably cough, wheeze, and feel tight in the chest. So it may be that a person with COPD is not truly allergic, but they don't like things that are flying around in the air. So.
All right. And for this next question, maybe you could just go over it briefly, because I know it's a fairly large topic, but what is the difference between pulmonary fibrosis and COPD?
Right.
And then also related to that, Carmen had said that you had mentioned that interstitial fibrosis has no cure.
Right.
And she's wondering if you have any suggestions, because she was diagnosed with mild interstitial fibrosis after being infected by COVID in December of
Right. Yeah.
2020. And she's still having shortness of breath upon exertion. And when she's going up and down the stairs, she's currently taking Symbicort and attending regular rehab, but the shortness of breath does not go away.
Right. Okay. Yeah. So I better be very careful here and remind people that I am not a physician. I'm certainly not a respirologist. So when I make these statements, I'm speaking in general terms based on my knowledge as a respiratory therapist and respiratory educator. So the first sort of challenge one might say is that interstitial lung diseases are an umbrella term. So just as COPD is an umbrella term, and COPD can include what we call smoking related COPD, it can include chronic persistent asthma that now doesn't respond very well to treatment. It can include asthma COPD in a combination. It can include conditions like bronchiolitis, bronchiectasis. There's many conditions that can result in an obstruction to air flowing out of the lungs. Well, when you look at interstitial lung diseases, there's many different forms of interstitial lung disease. So pulmonary fibrosis is one that most people have heard about. And idiopathic pulmonary fibrosis is sort of a subclass. So IPF, or idiopathic pulmonary fibrosis, for example, is nobody knows why you have it. Idiopathic meaning is of uncertain origin. So some people, for whatever reason, develop this interstitial lung disease, idiopathic pulmonary fibrosis, and nobody can determine why. So IPF, idiopathic pulmonary fibrosis would fall under the umbrella of an interstitial lung disease. Hypersensitivity pneumonitis would fall under the umbrella of an interstitial lung disease. The basic idea is that interstitial lung diseases actually affect the structure of the lung itself. So when we think about asthma, we're talking about the breathing tubes. So with asthma, the breathing tubes can narrow because of inflammation. They could narrow because of mucus in the breathing tube, and they can narrow because the muscles tighten. But in pure asthma, it's just the breathing tubes. There's no damage or injury to the little air sacs or alveoli of the lung. So it's an airways disease. COPD can be two things, meaning it can be damage to the breathing tubes of the lung. That's what many of us think of as bronchitis, chronic cough, and spit. So injury to the inner lining, production of mucus, muscle tightness, that's the airway manifestation or injury part of COPD. But we also understand that there can be emphysema, damage to the air sacs and the little blood vessels or capillaries around the air sacs. So that does involve damage to the structure of the lung, but it's destruction of air sacs or alveoli. The lungs therefore become very floppy. So in COPD, in particular for a person that has very severe emphysema, the lungs tend to be hyperinflated. They tend to be bigger than they should be because with the chest wall is always wanting to pull outwards a little bit, and the lungs themselves are very elastic. They're wanting to pull inwards. So there's this beautiful balance between the lung always wanting to come like this and the chest wall wanting to do this. And so the lung and the chest wall are in this perfect balance. And when emphysema starts to occur and you damage the air sacs of the lung becomes less elastic. It starts to get a little bit floppier. It doesn't have that elastic nature to pull it back to its normal spot. So that's why, weirdly or ironically, people with quite significant COPD with emphysema will have lungs that are massively big, hyperinflated on chest x-ray, and yet they'll be breathless. Why? Because their lungs are so damaged that they hold on to air and they don't let air go very well. So there's too much stale air in the lung. Now, I give you that background to contrast that with interstitial lung disease. So interstitial lung diseases, there's many of them. They are conditions that for whatever reason affect the actual air sacs or the structure of the lung. So there's what they call the interstitium, which is sort of the crossover point between the air sac, the alveoli, and the capillary or the blood. And so that little membrane or interstitium is meant to be very thin, and oxygen can transfer from the air sac into the blood, and carbon dioxide can go from the blood into the air sac to get exhaled. In different interstitial lung diseases, that interstitium gets too thick. it gets it creates scarring. And so in fibrotic lung conditions, that membrane that needs to allow oxygen to cross over, it doesn't work very well. So asbestosis, for example, asbestos exposure or asbestosis is a fibrotic type of lung condition. And what happens over time is the lungs end up being stiffer. So they're much more like a hot water bottle. So we all know if you tried to blow up a hot water bottle, it'd be very, very difficult because the hot water bottle doesn't have a lot of stretch to it. It's very stiff. And so people with interstitial type lung diseases tend to have lungs that are stiff and smaller than they should be. So COPD, super big, hold too much air, don't empty very well, and people get breathless because they're trying to breathe in and out little volumes because the lung doesn't empty. In interstitial lung diseases, the lungs are much stiffer and they don't expand as well. The other big difference is that in interstitial lung diseases, we're much more likely to see low oxygen levels. So I can see the vast majority of people with COPD, very, very breathless when they walk, for example. But if we stuck a little oximeter on your finger, it might say 94%. And you'd say, how does it say 94% when I'm so breathless? Well, we'll talk about that later in terms of what is actually the cause of breathlessness. So in COPD, breathlessness is the common symptom, but most of the time oxygen levels don't drop. In interstitial lung diseases, though, we are much more likely to see oxygen levels drop with breathlessness. So, any other?
No, thanks, Mark. I think
Okay.
yeah, we can move on to the rest of the
Okay.
questions on your sheet
Sure.
and we'll go back to
And please, yes, type out questions for Maureen as we go. So there was another question here. It's a really good one. It says, apparently I have a unilateral paralyzed diaphragm that's causing my shortness of breath. Is this considered COPD? And have you ever heard of it getting better? Really good question. So I'll try and act this one out. I might need to lower this camera and slide back a little bit. Okay, so I suppose I could stand up. Will that work? Let's see. Now you really get to look at my office. Okay, so if I was standing here and I was taking a breath in, the diaphragm is the big domed muscle that separates our lungs from our guts. And so what has to happen is the diaphragm needs to pull down, and as it pulls down or flattens, it draws the lungs with it, and that's how air comes into the lung. So we would say that inhalation is actually negative pressure. It's like a vacuum. This contraction of the diaphragm drawing the lungs, filling them up. So air is pulled into the lungs. And then when we exhale, the diaphragm comes back up again. Well, the diaphragm, we speak of it as a sort of a single unit, but it's actually two parts. There's the right and the left hemidiaphragm. So there's these two hemispheres or hemidiaphragms that make up the diaphragm itself. And in some people, one of these diaphragms can become inoperable. And there are many different reasons why that might be, and I don't know what they are, other than the phrenic nerve is one of the nerves, or is the primary nerve that powers the diaphragm. And so sometimes a person might have a surgery and maybe the right phrenic nerve is clicked, nicked, and so it doesn't work. Maybe there are other reasons like a car accident, something like that. But the bottom line is both of these diaphragms are meant to work in unison. If one of them doesn't, and this one says it's unilateral, meaning one of them is paralyzed, it's fixed. And so what you have is you have the bellows action on one side, but you don't have the bellows action on the other side. And so that breathlessness is mechanical. So a person could have a paralyzed hemidiaphragm, and they may have no overt lung disease at all, in that the diaphragm has nothing to do with lung disease as such. So in some people, they have underlying COPD and they have a partially paralyzed hemidiaphragm. Other people, that's it alone. And so there's a mechanical reason why breathlessness would ensue. Now, for anybody that has a paralyzed or partially paralyzed diaphragm with or without COPD, really, really, really important to practice breath control. So in COPD, I hope that all of you are familiar with pursed lip breathing. blowing air out like you're cooling soup or blowing out candles on a cake. That back pressure that you create at the lips is essential to create those columns of air that travel back into the breathing tubes and hold them open from the inside. Because with COPD, when you push, when you're doing the blowing test, the harder you push with an open mouth, the more the breathing tubes are collapsing. And so we need to keep the breathing tubes open by blowing out against a little bit of back pressure. Now, when we think about this diaphragm problem, so normally what happens is the diaphragm pulls down, and that's how we breathe in. What happens when part of it is not functioning, the good part pulls down, and this one tends to do this. It tends to actually lift up a little bit. So when people are really trying to pull air into the lungs, we understand why people do that. The instinctive response to breathlessness is to try and pull air into the lungs because we think we need oxygen. That's not actually what's happening. So we'll talk a little bit about what the brain thinks is happening and what is. So you can help to remedy this other bad diaphragm or the paralyzed diaphragm kind of pulling up even further when you're breathing in. We would call it paradoxical movement. You can actually help that out by pursed lip breathing. So pursed lip breathing is the best way to try and limit the breathlessness that this paralyzed diaphragm causes people. So if I was walking, for example, again, regardless of the reason for my breathlessness, I would typically be breathing like that because the breathlessness makes me want to catch my breath, breathe in. If we have a partially paralyzed diaphragm, we want to try and use that pursed lip breathing technique to try and stabilize this diaphragm that doesn't work. So blowing out like you're cooling soup, that's the first P, pursed lip breathing, cool the soup, smell the flowers. The second P, pacing, slow breathing down as opposed to faster, which is again an instinct. And the third is posture. Because if you watch anybody that's breathless, we're typically doing that because we're lifting the chest up, trying to pull more air into the lungs because that's the innate instinctive reaction to breathlessness. That actually doesn't help us. And we'll get into more discussion about that specifically with COPD in terms of tricks or strategies to reduce breathlessness with everyday activities. But I just wanted to sort of leave that. So no, having a paralyzed diaphragm is not the same thing as COPD. Can it get better? In most cases that I'm familiar with, it doesn't, because there's a mechanical reason. Either there's nerve damage or something that makes the diaphragm not function on that side. But it's a good question for a physician. Sometimes cardiothoracic surgeons can do some diaphragmatic surgery to see if they can, if it's a phrenic nerve, correct that problem. But okay, I'm not familiar. So, hi, Mark. I've had a raspy, hoarse voice for about 6 years. At that time, it started off only getting hoarse about 1 hour after choir practice and recuperating. Now it gets increasingly worse as I use my voice during the day, and at times it takes an effort to speak as my voice gets very tired. Have had scopes and no one has found anything significant. This is a question from Janet. Wonder if anybody else with COPD has had a similar experience and has found any remedy. Do you have any suggestions? Well, typically when I talk to people who have COPD, they're typically taking inhaler medicines. So some of the inhaler medicines can cause an effect on voice. So certainly inhaler medicines that contain a steroid can sometimes result in this dysphonia or voice hoarseness, dry throat, irritated throat. Other medicines, though, that are specifically related to COPD, like LAMAs, Incruz, Spiriva, medicines like that, those can cause some dryness or hoarseness of the voice. Interesting thing is, if you've had it for 6 years, the question would be, have you had it ever since you started taking an inhaler? Meaning, is there some correlation between inhaler use? The other reality is that for anybody that has COPD, we expect them to typically be in their 50s, 60s, or 70s. And sometimes other medicines we take can cause a lot of throat dryness. So being dehydrated is certainly a potentially common experience depending on what medicines we're taking. We would always want to know, is there anything to do with either postnasal drip going on? So do you have to do a lot of that, or do you feel some irritation at the back of the throat? Clearly, when you've had somebody look at your throat, what they could be saying is there's no anatomical or structural reason for your symptom. It doesn't mean that you couldn't have postnasal drip. The other thing might be heartburn or reflux, if that's something that can affect the voice or the throat. Another thing that I would put forward is that breathlessness can actually be a complicating factor for a hoarse voice. So, for example, if I have very, very severe COPD, and I'm not saying this is a criticism of you, Janet, I'm just making a general statement. If somebody has COPD and they're breathless, if they tend to breathe or sing a little bit breathless, we all understand the basics that we have to have a flow of air out of the lungs through the vocal cords to create a sound. And if I am more breathless, I don't have as much volume to push through. So, I may strain my voice to create the same power or tone because I don't have as much volume, because I'm breathing in and out and in and out a little bit more shallowly. So some people who do have COPD or asthma or interstitial lung disease, meaning if they're breathless, they may be straining their voice a little bit more because of their breathlessness to try and generate the same volume or tone. So people who I see who use their voice a lot for speaking, they will sometimes say, oh my gosh, I can't believe how ratchy my voice is. I'm not quite sure. And it may be that they're actually straining their voice because of their breathlessness, if that makes sense. So sometimes that could be the reason, but certainly one thing would be, do you use inhalers? What are they? Do you have practice good inhaler technique? Are there other medicines you're on that might contribute to the breathlessness? And then are you possibly straining to create the same tone or volume you have in the past? So speech language pathologists are very good for people who are having voice issues. If there isn't an anatomical or structural reason, sometimes people will see speech language to help them relax or train their throat, just like a person would go to a singing coach, a voice coach, right? I'm in Victoria and I do not have a doctor. Surprise, surprise. I have seen you, oh my gosh, and have been tested at RGH. Am I able to book an appointment for updated testing? Yes. So anybody that's come through my office who has the COPD or asthma or anything like that, you can contact the office directly and say, hello, it's Bob or Sue, and I'd like to have an appointment with Mark. A lot of them I'm doing just over the phone to start, but yes, you could call. So for those Victoria people, 250-370-8265. If I've seen you in the past and you think there would be good reason to get in touch, you don't need to be referred again, okay? If you haven't got a diagnosis though of asthma or COPD or something, I can't really see you, if that makes sense, right? You have to have a diagnosis. Oh gosh, I'm going to steer clear of the COVID questions because I'm not that knowledgeable. COVID test kits are now available for pickup at pharmacies if you're over 50. If you were to test positive for COVID, would you recommend seeking medical advice immediately because of COPD, or would you say it's okay just to monitor for severity, knowing that there are now treatments that are effective if started early? I would say yes. So COVID, any flu, any virus can trigger COPD to get worse. And what we would encourage people to do is to follow their COPD flare plan. So Doctors of BC COPD flare-up plan would be, if I have sustained breathlessness that persists for more than 48 hours above my normal, if I have an increase in cough and mucus production, and I'm coughing more mucus and my mucus looks purulent, discolored, green, if that persists for more than 48 hours, I, by definition, I am having a COPD exacerbation. So Whether we look at a cold, whether we look at COVID, we would be monitoring for, am I more breathless than normal? Yes or no. Am I coughing more than normal? Yes or no. Am I coughing up more spit than normal? Yes or no. And is this sustained for more than 48 hours? If it is, then we would initiate our plan of action. For some people, that would be call their physician or specialist. If you don't have one, it would be, okay, do I have prednisone or do I have antibiotics? Okay, yes, I need to think about those. Prednisone for the breathlessness that doesn't seem to be resolving, antibiotics for the increase in mucus and change in purulence, color of my spit. So any type of cold or flu or virus can trigger an increase in symptoms. It's not that COVID is necessarily worse or better than any of them in that in certainly the world that I work in and live in, we've had relatively few people with COPD that's in our sphere get COPD and really get into trouble. So it doesn't mean that having COPD doesn't mean you're immune. Clearly it doesn't. I'm not saying that in any way, shape, or form, but with some of the Delta variants, when you look at who got sick and who died, they could be 40 years of age, completely healthy, no underlying lung disease, no diabetes. They got, COVID Delta variant, and bam, they were dead within a week. So the reality is, they still don't really understand why some people get COVID and they get really sick. Some people get COVID, they don't get as sick. Certainly, Omicron is much more of an upper airway condition. So people tend to get more of the sore throat, the cough, and the spit. They don't get the terrible breathlessness and the very significant interstitial looking lung disease that the Delta variant caused. So the Omicron is fortunately much milder in that case. So what we would say is any cold or flu can cause significant grief for a person with COPD. Monitor your symptoms, have an action plan. Now, with regards to salbutamol, the blue spray, Atrovent, the white puffer with the green cap, or Combivent, the orange turn and click inhaler, all of those would be encouraged for somebody to use if they say, I've picked up something and I don't know why I'm more breathless, I have a cough and I'm wheezy. Use those inhalers. That's what they're there for. Use them quite aggressively, because sometimes if we use these bronchodilators quite aggressively, the COPD doesn't go downhill as rapidly, meaning we can get maybe ourselves out of this flare by being very aggressive with bronchodilators. So that's the time to use it. And most people will say, oh yeah, my salbutamol says may use every 2 to 4 hours up to, X number of times per day, or 2 to 4 puffs every 4 to 6 hours, whatever it might say. So the idea is, when you're more symptomatic and you think you've got a cold or a virus, be aggressive with your bronchodilators and know that within 48 hours, if you're not getting any better, you need to kick into the next step, which would be contact a physician, the nurse's line, a walk-in clinic, an urgent care center, or initiate your action plan. So prednisone is for breathlessness. An antibiotic is for the infection. So the challenge we all have in terms of, well, do I or don't take an antibiotic? The respirologist would have the same debate that you would. There's no test that they could administer to you. So they would say, are you coughing up more mucus than is normal for you? Yes or no? Does the mucus you cough up seem to be thicker or in greater amount? Yes. Does the mucus have a different color? Is it starting to look greenish, or what we would call purulent? So if you answered yes, yes, and yes, we'd say you have an infection, begin your antibiotic. In the vast majority of cases, when people have a flare up for COPD, it would be prednisone and antibiotic at the same time. Okay. Now we can come back to that, but I'll just leave that for a minute because I just want to get on to these other questions before, of course, we run out of time. I was wondering, with COPD, can you use or should you use diffusers with the different scents? Depends on whether it bothers you. So I can meet many people that say, oh my God, I can't even stand a scented candle, let alone a diffuser. Other people say, I love my diffuser. We'd say, good. Diffusers in no way, shape, or form are necessarily bad for people. What I think we should all simply keep in mind is that anything we breathe in that isn't air is a potential irritant. So I like incense. That's smoke. I mean, that's a crazy thing for me to breathe in. I don't have my head, directly over it, but I love it in the back of my, sitting room. I love that smell. But I'm lucky in that I don't have asthma and I don't have COPD. So for many people, they would say, I don't like diffusers, I don't like perfume, I don't like any scented product, I don't use anything that's a spray. I put Windex onto a cloth and I clean my window like that. I don't spray anything. So for some people, diffusers are great and they don't cause them grief. For other people, it says, oh my God, that's terrible. So I have COPD and the amount of air I can breathe in is only 2 seconds. I can breathe out for at least 6 seconds or more. Also, I get a plugged up nose and that makes it very hard to breathe. When I walk my dog, I run out of air very quickly. Are there any tips you have for dealing with these issues? So what I would say is absolutely. So here's where we get into the nature of breathlessness. So the human brain is conditioned to think of breathlessness as I need more air. So people will describe air hunger. They will say, I can't take a deep breath. I feel as if I need oxygen. Well, let's be very clear here. I'm going to put interstitial lung disease over on this side, and I'm going to put very severe COPD with people who are already on oxygen over to this side. So what I'm really speaking about is the general experience of most people with asthma or COPD. They will experience breathlessness when they walk, particularly if they go up a hill. So we'll talk about why that is. The first thing to understand about this question is I can breathe in for 2 seconds, but I blow out for 6. That is the classic problem of COPD. It should be that the in and the out of breathing are the same. In, out, in, out, in, out, in, out. Meaning when we do physical activity, we simply breathe faster and we breathe more deeply because the lung can empty just as fast as it fills up. In, out, in, out. It's an amazing system. It's a bellows action. The problem in COPD is that the lungs are too slow to empty. That's why we always measure and confirm your COPD-ness by how well or not well your lungs empty. Oh, my FEV1 is 40%, or my lungs empty at a 57% or 72% level. What that means is they don't empty as efficiently as they should. So as soon as you start to walk and you have to breathe in and out more quickly, your lungs don't empty very well. They're slow. And so what actually is happening is your lungs are backing up rather like the sink. So the analogy that I give for people is, you wash your hands at the sink, you turn the taps off, and while you're drying your hands, you look at the sink and go, oh, bother, the sink's backing up. Meaning, if the water is going into the sink faster than it goes down the drain, the water level in the sink keeps rising. Why? Because there's something obstructing the water from emptying the sink. That's what happens with COPD. Just by the mechanics of how breathing works, the lungs will always fill up. Always, 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 always. They can fill up, but they don't empty very well. So COPD, chronic obstructive pulmonary disease or asthma, is always a lung emptying problem. And so when we walk and our breathing gets faster, the shorter the time the lung has to empty. So it fills up, doesn't really empty, fills up, doesn't really empty, fills up, doesn't really empty, gets fuller and fuller. Now, there's all the sort of the behind the scenes biochemistry of what's going on and carbon dioxide levels and oxygen levels, but really that's, I don't think, particularly helpful for most people to know. What's probably more important to know is, well, what is the actual cause of my breathlessness? Well, not to be crude or funny here, but think about peeing for a minute. Yeah, peeing. How do we know when it's time to go pee? Well, the bladder is filling with urine from the kidneys. And as the bladder is filling with urine, the bladder starts to stretch. And as the bladder is stretching, little fibers in the wall of the bladder, stretch receptors, how clever, they start to give us the physical sensation, oh boy, I think I better go pee. And then the brain knows what that means. And for any of us that have had kids, it's like, oh my God, little Jimmy knew it was time to go pee and they went to the potty because they recognized what this feeling was and then what it meant and they went to pee. So it's a mechanical pressure system. More pee in the bladder, more pressure. We notice it. The brain says, oh, go pee. We void, we feel better. The lungs have stretch receptors. So normally what happens is it's fill and empty and fill and empty and fill and empty. But with COPD, it's the lungs getting a bit fuller and they're not getting emptied. So these stretch receptors are firing and the brain is interpreting this going, oh my God, this is awful. I'm getting more and more breathless. Well, feels like my lungs are too small. I must need more oxygen. No, it has nothing to do with oxygen level. That's why when you put the probe on, they'll go, it's 95, and you're going, what? How can it be 95? It's because your stretch receptors are just activated constantly, and the brain is having to interpret, because COPD, let's face it, is abnormal. And so the common instinctive reaction with breathlessness is faster, deeper breathing. And the more you do that, the worse it gets. So that's why the best way to treat COPD is by doing things that inherently seem a bit odd. They seem backwards. Slow my breathing down. What? Blow out more than you breathe in. What? Relax my shoulders. What? So for some people, controlling breathlessness initially is a really weird idea because you're doing three things that are not instinctive. So we would describe them as the 3 P's of breath control. Pursed lip breathing. You blow out like you're cooling soup or blowing out candles on a cake. The second one, pacing, slow your breathing down, give the lung more time to empty. And the third one, posture. Try and get those shoulders more relaxed. So a person could go from this to and I know it's easy for me to demonstrate because I don't have COPD. So I appreciate if there's anybody out there, it's not so simple, and I recognize that. But the basic idea is blowing it out against that little bit of back pressure is absolutely essential. That's foundational to this whole idea. It's why when you push with spirometry, everything gets so bad. So we need that little bit of back pressure. This is my 5-cent teaching tool that Island Health gave me. So if you think about this, this is a very floppy breathing tube. But if I get a column of air into that little bit of floppy tube, it stays open. So it's that idea, blowing out against that little bit of pressure opens the breathing tubes, keeps them open so that the lung can empty. Everything is about helping the lung to empty. So we would say, cool the soup, smell the roses. The idea of trying to breathe through the nose is we're trying to overcome the natural instinctive desire for gasping. We're desperate for air, and so we try and suck air in through the mouth, which unfortunately only recreates and further worsens the same problem. So it's cool the soup, smell the roses if we're able. The second piece, slow breathing down. Slow breathing down. Give the lungs more time to empty. So it's exhaling for 2, 3, 4, 5 seconds, then taking a breath in. It's never blowing out till you feel miserable. It's never forcing the air out. If you tried to blow too hard onto a bowl of soup, you'd be spitting on it. So it's no more forceful than that. Okay. So pacing, slow your breathing down. Posture happens because of the old diaphragm. So if somebody has particularly significant emphysema with their COPD, so the diaphragm, should be doing this. Well, what happens is as the air is starting to back up in the lungs and the diaphragm is actually getting flatter, meaning the lungs can't go up because of the collarbone, they can't go forwards because of the breastbone or backwards because of the spine. So when they say hyperinflation of lungs on chest x-ray, they mean you got nice big lungs, but that's actually not something you want in this case because it means that the diaphragm, instead of being here, is down there. And so if the diaphragm is flat and it can't rise up and draw down, we end up lifting the chest up and down, trying to pull air into the lungs. And that's why sometimes people will say, oh, I feel so tight in my upper chest or the muscles across my back. I don't know why they're so tight. I get so sore. It's because people are lifting their chest up and down to breathe because that's the innate sort of response to breathlessness. So if we can get the shoulders looser and more relaxed, that helps the mechanics of breathing. How do we accomplish that? By slowing breathing down, letting the lung empty. Oh, now the diaphragm can start to come back into the scheme of things. So some people have very severe emphysema as a part of their COPD, and they will notice, for example, that when they get up out of a chair, as soon as they walk towards the kitchen, they're immediately breathless. And that's because we do a lot of innate things with breathing that we wouldn't think about. So when I stand up, and we all stand up, I actually take a little bit of a breath in, and then when I walk forward, I take another breath in. But because my lungs can do that, I don't notice it. But if I had quite severe COPD, I might notice that just walking 5 feet, oh my God, I'm breathless. Well, the good news is you're not breathless because there's an oxygen deficit. But the bad news, or the tough part of it, is this is where breath control techniques come into play, meaning starting to think about what am I doing and why do I get breathless? So what people can learn to do is that when they get up out of the chair, they can do this, get up out of the chair, just relax the shoulders for a minute, empty the lungs, and then when you start walking forward, you can actually start to use your pursed lip breathing right then and there. So the whole idea about pursed lip breathing is not, I repeat, not you need to be doing this 24 hours a day, 7 days a week. But when you're doing something physical, especially with higher severity or worse severity of the COPD, the more beneficial it'll be. So we would say when you're doing something physical, breathing more quickly because you're walking, use pursed lip breathing. The idea is you try and use pursed lip breathing to avoid you having to stop because you're so breathless, rather than use pursed lip breathing only when you're breathless to catch your breathing back again, so to speak. Because the sort of recognized consequence sometimes of persistent breathlessness is fatigue and tiredness. And thank you for the questions. Maureen will prompt me to answer them a little bit later. So the bottom line is people who are persistently breathless are going to be more fatigued and tired. So the immediate benefit of pursed lip breathing or breath control strategies is reducing breathlessness in the moment, but the long-term benefit is, oh, I don't think I'm quite as worn out or tired. So let me give you an example of what I'm getting at. So if I was carrying bags of groceries, so if I had a bag of groceries in either hand, a lot of you may be starting to think, oh yeah, okay, I know what he's talking about. I think when I go into the grocery store and I don't have the grocery bags, I feel breathless, but I'm okay. But when I have the bags of groceries and I'm putting them in the car, or I'm taking them from the car into the house, holy beep, I get breathless. Now, you're not breathless because of the mechanical load and gravity and oxygen consumption. You're more than likely breathless because of how you tend to breathe when you're breathless. So if I was breathless with COPD, I might be breathing when my chest is lifting up and down like that. Now, that doesn't seem like a lot of breathlessness, and it's not bad. It's not going to kill you. It's not harmful in any way, shape, or form. But these muscles, these accessory muscles, they're not really meant to lift the chest up and down like that. And certainly when you're carrying bags of groceries, the muscles of the chest and the shoulder and the back, they're meant to support the arm so you can carry the groceries. They're not meant to do the breathing. So if you're trying to breathe and carry things at the same time, you can't do both. And so the lizard brain is smart enough that it knows, man, oh man, if I take a breath when I'm carrying this, I'm going to drop the bag of groceries. So what people do is they actually have periods of time where they hold their breath. And so people will often say, oh my God, that's me. When I come in the front door of the house, I put them down on the table and I go, because they've been holding their breath for the last few steps because there's something in their subconscious that says, if I take a breath now, I got to drop everything. So pursed lip breathing takes off this stress because you're not lifting the chest up and down, up and down, up and down, which is messing up the ability to carry things. Even simple things like carrying a laundry hamper, carrying dishes from one room to the other. You have to use these muscles to hold the dishes. But if you use these muscles to breathe, you can't. Pursed lip breathing and pacing, once again, this idea of posture. What's my posture doing? Why is my COPD affecting posture? Oh, breath control. Even something as simple as I bend down to get something from the dishwasher, we all hold our breath when we bend over. If you don't have COPD, it's not an issue. But if you do have COPD, it can be a big problem. So pursed lip breathing when you bend over to put something away. Pursed lip breathing when you're mopping, as opposed to, and if I had more time, I would demonstrate more elegantly. But what I'm trying to get at is there are certain activities that people do, which we can explain based on the changes in the mechanics of breathing, and that people can radically change by understanding, again, the 3 Ps and why their breathlessness is occurring. So pursed lip breathing and pacing when you're carrying things, hugely important. The other universal truth for people with COPD or asthma or any type of lung condition is traditionally they don't like going up hills. And so some people are very clever. They somehow, are secret members of the Flat Earth Society, and they figured out all the flattest routes to get from here to there because hills are so bad. Again, it's not that you're working against gravity and your muscles are sucking oxygen. It's really because when we walk up a set of stairs, for example, kinesiologists have studied this. And when we go up a set of stairs, the body is lifting or rising, the chest is going up. So inherently, we take a breath in when we start up the stairs. In, out, as we go up the stairs. That's a massive problem with COPD. As soon as we start up the stairs, our lungs are already starting to back up. And because they don't empty very well, and there's this exaggerated emphasis on breathing in, we're breathless before we've got even halfway up the set of stairs. So people don't like the stairs. They don't like hills. It's the same thing with the hill as we're going up. So the mantra is blow out to go up. When you start walking up those stairs, it's like this: out, in, for example. Now it might be 2 stairs of blowing out, or 3 or 4, depending on your breathlessness, et cetera, et cetera, et cetera. But the bottom line is breathlessness with hills and stairs is a mechanical air trapping problem. And so when people avoid stairs, we get why. When they avoid hills, we get why. I'm too breathless, I can't do it. The problem with that, all of us inherently understand, is that the fewer times I do hills or stairs, the more physical strength and deconditioning occurs. And therefore, everything else I do, I'm not quite as able. So that's why breathlessness is not always about the lungs. It's about the lungs, yes, as the starting point, but then it's about the muscles that are weaker because we can't do stairs, and stairs are really good to help strengthen the muscles. The front muscles, the muscles of the front of the leg when we go up, and the bum muscles when we're going down. So if you can start to incorporate hills or stairs, you don't have to do all 15 stairs. If you've got 15 stairs, maybe go up 4 or 5 of them and say, that was pretty good workout. I'm going to turn around and go back down again. But learning this technique of blowing out to go up is a weird idea. But what will happen is, in the vast majority of cases, the practice or the use of pursed lip breathing, pacing, and posture is hard work. It's conscious thought, breath control. This is a weird idea. Slowing my breathing down, blowing. But the more you do it, the more you'll start to do it, and the more you'll start to go, I'll be damned. That's helpful. And the great story is that the brain is really adaptive, and the brain really, really likes the decreased breathlessness that you feel when you use these breathing techniques. So you will have that wonderful eureka or aha moment when you, oh my God, I went up the stairs and I didn't actually have to think about this thing, because your brain will start to recognize that it works, and you will start to do it instinctively. It's just like one of the reasons that hills and stairs cause so much breathlessness is because when people start to go up the stairs, they almost universally take this big gulp full of air because people think I need lots of oxygen to help me to go up, not realizing that what they're doing is they're filling up their lungs so there's even less room, and so their breathlessness actually gets worse. Okay.
All right. Sorry to interrupt, Mark. Just wanted to let you know that the time is 20 after 2. Is it okay if you stay maybe for another 10 minutes?
Sure, absolutely.
Yeah, okay. And for any participants in the room, if you do need to go, you can just leave quietly. Feel free to do that. We'll understand. And like I said, this is being recorded. that'll be made available on our YouTube channel within the next couple of days. So like while you're on the topic of breathlessness, there's actually a couple of questions sort of related to that. So Maureen Silver is asking, how does exercise classes benefit me? And she's saying that she can't walk very far without getting out of breath, but if I push myself, will that improve my endurance?
Oh, brilliant. It's like she's a plant in terms of, really, really good questions. So first and foremost, the thing to keep in mind with exercise, and this is for able-bodied persons in terms of function, lungs, that is, we do not exercise to make our lungs better. So if Katrina said, I'm going to go for a run and I'm going to make my lungs better and stronger, and that's going to make me less breathless, that's not how it works. We exercise to make our body, the muscles that surround our lungs, fitter and more conditioned. So the elite athlete has unbelievably efficient muscles that don't use and require a lot of oxygen, and they have a very, very high threshold. So we get that basic idea. So the purpose of exercise in COPD is super, super, super important. In fact, it's important with all types of interstitial lung disease, all types of asthma, all types of COPD, particularly with COPD though, when we look at the challenge. So the primary symptom of COPD is almost universally breathlessness. So if I'm breathless, I can't walk very far to do something because my breathlessness stops me. Understood. If it's your lungs that are stopping you, you're not getting the fitness that you're looking for. So one of the key messages is you do not want to exercise until you're forced to stop. That is a big challenge because for the previous 50, 60 years of our life, depending on how old we are, we would say, if I get out there and work my bum off and I keep going up and down that hill, I'm going to be super breathless when I start, but I'm going to get less and less and less breathless as I go. That's the concept of fitness, push against the breathlessness. You don't want to do that with COPD. It does not work well because breathlessness will primarily be a COPD problem. So we need to remember that if we can't control our breathlessness, we need to slow down or stop. So two, I think, helpful ideas that I've gotten from our physio experts here at the Jubilee would be, you should be able to say your 10-digit phone number. Meaning if you're trying to figure, well, how breathless should I be? If you're 250-3708-265, if you're that breathless, you're too breathless. You should be able to say your 10-digit phone number. So you shouldn't be able to whistle a tune, but you should be able to say your phone number. The other idea would be you should never, ever exercise to the point where you're forced to stop. So pushing yourself and say, man, I could walk to that telephone pole, but if I did, I'd be spent. That would be it. Don't do that. So part of the challenge really with fitness and exercise in COPD or any lung condition is being patient, is by saying, if I push myself too hard until I can't go any further, I'm not going to actually get any better. And so you can use this rather harsh but important teaching tool. If you feel that you are working hard to get fitter and stronger and you're not noticing that you're getting any better, you're probably pushing it. So if a person says, I can walk 2/3 of the way up the hill, but man, oh man, that's it. Don't do 2/3 of the way up the hill. Maybe do 1/2 of the way up the hill and say, I could go a bit further, but I'm not going to, and then going back down again. So just like any athlete who has injured themselves, they really should follow a very strict plan of strengthening, flexibility, aerobic conditioning, cardiovascular training, and they don't push any further than this. And they have a very regimented plan to get them back to where they would like to be. We really need to do the same thing. We need to respect our body, that we may be more breathless because we've been inactive for 2 years. We may be more breathless because we have underlying COPD. We may be more breathless because we have some arthritis, and that makes our shoulder very stiff and sore. And so we have a mechanical reason for breathlessness. We have pain in our knee, so we hold ourselves kind of funny. So we need to keep all these things in mind. And ultimately, breath control, breath control, breath control. Do not push yourself to the point where you're forced to stop. It does not work. And if you go to some of the Lung Foundation information, or if you go to livingwellwithcopd.com, so Living Well with COPD is a great program made in Canada, Jean Bourbeau, Montreal Chest Institute. You can watch videos, you can follow exercise programs there. BC Lung has a wonderful webinar series. You're probably familiar with that, where you can actually work either with kinesiologists or RTs or physios. So there are online resources. So breath control, breath control, breath control. Do not push yourself to the point where you're forced to stop.
Sounds good.
Will you ever get better? I mean, will you ever be able to walk further unless you push yourself?
Absolutely. It's an excellent question. You're absolutely correct to think that if you do not exercise, you will never be able to walk further. However, we also must be very reasonable about the mechanics that we're talking about. So if somebody has lung function of 50%, for example, and they say, I really, really, really want to be able to walk up Mount Douglas Hill here in Victoria, or I really want to be able to walk up the hill to Queen Elizabeth Park, or I really, really want to walk up the hill in North Vancouver, you may be in for a tough fight because that just may not be within your body's physical capability. But if you say, I want to be able to walk from here to the grocery store, to be able to walk with my grandchildren, to be able to walk with my husband, I want to be able to go for a walk and deal with hills and stairs, absolutely, you can do that. So we do need to be mindful that whether a person has a bad knee or a bad hip or impaired vision, there are certain things that really we're not going to be able to do very well. So it's not about saying I have to give up. It's about how can I adapt and how can I use breath control to limit my breathlessness so that I can gain physical fitness. I've had some people that I've met who have had such severe lung disease and such severe breathlessness that 30 seconds of exercise was all they could manage. And yet after 6 months, they're walking for 10 minutes. So it really is about using your breath control, being as physically active as you can, listening and remembering your limits and saying, well, that may be it for now, but I think that I can continue to get better. So it's not about doing things quickly. It's more about endurance, if that makes sense. You want to be kind of like a marathon runner rather than a sprinter.
Okay. Thank you. Thank you very much.
You're welcome.
Okay, great. I've got a couple of questions that are medication related. And, so Brad wants to know, like many of the COPD medications require you to take a deep breath to inhale the medication into your lungs. If you're not able to take a deep breath, are there other methods to be able to get the full benefit of these medications? And Beverly followed that up with, could you explain inhalers with a chamber without holding your breath?
Sure. Excellent. Really good questions. So ultimately, was it Brad who asked the
Yes.
first question? Brad. Yeah, it's an excellent question. So one of the things that I will talk to, with physicians or young medical residents is, the great irony for anybody taking a COPD inhaler is that you've got impaired lung function to start with. So the question earlier that said, I can breathe in for 2 seconds, but I can blow out for 6. That's the physics or the math, so to speak, of COPD in a nutshell. So the reality is you can empty forever. So what happens is this: when your lungs don't empty very well, they're always a little bit fuller of air than you would think. So your ability to take a breath in is quite limited. But if you use the 3 standard recommendations of inhaler technique, so always stand when you take inhalers. Unless you've got a balance impairment or you're in a wheelchair, always stand up. Choirs always sing standing because our belly gets out of the way. So always stand. Number 2, always be looking forward so that your throat is open. When we hold things, we tend to look at what we're holding and we lean towards it. Believe it or not, that angle that we create is awkward. This is the orientation we want to be in. Number 3, this really refers to Brad's point. We want to use our pursed lip breathing to comfortably allow the lung to empty so that the breath in is deeper. And I'll just show you with myself. So if you pretend that this white puffer is salbutamol and I'm using my spacer, I am just doing normal breathing like me. I'm not trying to exaggerate anything. So if I took it like this, that's as full and deep a breath as I could take. And I would think, well, that's pretty damn good. But let's pretend I've shaken it. If I do this, blow out with pursed lips first, look at how much deeper a breath I took. So one of the misconceptions about I can't use my inhaler very well, I'm not criticizing you, Brad, or anybody, but one of the misperceptions is that I'm not strong enough to breathe the medicine in. Probably what is more true is that your lungs aren't empty enough to pull the volume to generate the pressure. You need a volume to generate this flow to pull the medicine out of the device. So it's always stand, always look forward, use your pursed lips to comfortably empty the lung. Therefore, the breath in can generate enough flow to bring the medicine in the lung. Because the reality is people with COPD have big lungs. So it's not a volume problem. It's that you're breathing in very shallowly. Okay. Now, the other question, oh, right. So if I had COPD or asthma for that matter, and I was really, really breathless. So let's say I had a cough or I was so breathless and I was trying to take salbutamol or Atrovent. One of the challenges is clearly I can't do all that magnificent stuff. So this particular spacer has a little flap, and I don't know if you can see that, but all spacers have some sort of a valve. It's either internal, it's a diaphragm pushing in and out, or a little flap. So if I was really breathless, what I could do is rebreathe. So I could spray it and then I could breathe in and blow out through my mouth. This little flap opens so I exhale, but I'm not losing any of the medicine that I didn't inhale the first time around. So I could do this. Or if I was coughing, so when I inhale, I'm getting a little bit of medicine. Then when I cough, this little valve opens up, but I'm not actually losing anything that I didn't inhale the first time. So the rebreathing technique is really, really helpful when you're very breathless. You know you can't do a full deep breath. You can't hold your breath because you're coughing, you're wheezing. So yes, the old either blue puffer of salbutamol or the white puffer with the green cap Atrovent, they're very helpful when you use them with the spacer when you're really breathless. Okay. Sorry, go ahead.
No, go ahead. Sorry. Yep.
No, I was just going to say all inhalers, whether we're talking about powdered or mist, we want to follow the same basic mantra. Stand, look forward, blow out gently before we inhale. So if we have a powdered device, we simply want to get the device ready, click before we start the process. And then inhale. So we don't have to worry with a powdered inhaler that, oh, it's going to fall out, meaning we need to load the device when it's straight up and down like a candle, turn and click, or powder, click. But once the device is loaded, we can and should hold it in this orientation. We need the throat to be more open, okay? And for those people that might use Symbicort, here's another important little, not trick, but feature. Very important to put your teeth and lips very gently on that little flange. If you had it just inside your mouth, you could be pulling the medicine into your teeth. So just very gently. Same thing with this particular one, the Respimat. When we turn and click, we want to have our teeth just very gently, okay? And with this particular device, so this would be Spiriva, Inspialto, or Combivent. Some people will find that when they inhale, it makes them cough. Good question, Terry. We'll answer that in a minute. When people breathe Spiriva, Combivent, or Inspialto, sometimes they notice it tickles their throat and they breathe in, for example, makes them cough. Try a sip of water to coat the back of the throat with some moisture, and then use your inhaler, and you might find it doesn't cough because it's really just the irritation. So yeah, okay. Gina, good question. So somebody asked about teeth. So if you have dentures, the recommendation is always to have your dentures in when you use inhalers, because it's amazing how much narrower your mouth becomes when you don't have teeth or dentures to when you do. So if you wear dentures or have a plate, it would be recommended that you have them in when you're taking your inhalers. Otherwise, your mouth is that much closer together and you lose more medicine in the mouth, okay? The other question that was asked was, why do we use such big honking mouthpieces in the pulmonary function lab? And I hate to tell, it's just because we're mean. We can get away with it. We could change to much more convenient ones, but we don't like to. No. So seriously, the reason is because we're exactly, haha, Gina. No, it's because we're trying to take the mouth out of the equation in terms of, we know, for example, that if we use pursed lip breathing, that back pressure helps to allow the lung to empty. So we can manipulate how the lungs work by what we're doing with our lips. In normal lung function, it should be that if you have a big honking tube and you blow hard, the harder you blow, the faster it comes out. The problem is in asthma and COPD, it's the exact opposite. The harder you blow, the worse your lungs empty. And so really spirometry is a stress test for the lung. Like, you know, you have an ECG and you're lying still, it's normal. And then you remember to tell the doctor, oh, I forgot to tell you that I got this funny feeling in my heart when I was going up the stairs. So they say, oh, well, we better do a stress test, right? Get you on the treadmill and work you to an inch of your life. The idea being they want to see what your heart does when you work it. Does it do funny things when it's stressed? That's what spirometry is about. Blowing forcefully is a stress for the lungs, but it shouldn't manifest in any way of coughing, wheezing, or an inability to empty. So long-winded answer, that's why the mouthpiece is so big.
All right, thank you, Mark. Okay, so just, I think we'll make this one the last question since you are with Island Health. Sharon wants to know if there is anywhere on the island that is providing pulmonary classes. She lives mid-island and she's been wanting to access this type of program, but every time she checks the website, it just says coming soon. Do you know what services are coming?
No. So Kat has certainly heard my rant on this before, and I wish that I could say something different after I've been here for 20-something years. Island Health is one of the worst health authorities in terms of rehab programs available. I'm embarrassed to admit that that's true, but you could certainly get in touch with Island Health and say, hey, where do I go? And they'll say, well, blah, 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 blah. So the reality is, no, we don't have anything in Nanaimo. We used to have something in Cowichan. That doesn't help you, obviously. We have one program for all of Vancouver Island in Victoria, which is only accessible to patients of the respirologists that are in our area. So in Victoria, which I know is not helpful for Up Island, we have some community rec centers. We have Henderson Rec Center, Panorama Rec Center, and Saanich Commonwealth Pool. They have what they call Take Heart, Breathe Well. It's much more cardiac oriented, but there are programs at those locations that are appropriate for people with COPD. They do have quite a hefty price tag, probably about $350 to $450, which is a huge factor for many people. Other health authorities, the rehab programs are available at no charge because the health authority clearly recognizes that rehab and exercise is the most important therapy that they could offer you. And it's remarkably cheap in the scheme of things. So that's a very long-winded answer to say, no, unfortunately, we do not have any programs mid-island. And I would encourage you to politely or impolitely rant as much as you are able to encourage BC Lung to do what they continue to do, which is act as an advocate for you, but also to rant directly to your physician and your health authority, because we are terrible. We're shockingly bad all across the country. We're pretty bad across BC, but we're particularly bad in Island Health. So what I would say is the evidence is very, very clear that if a person learns to the best of their ability about breath control, if they're on appropriate bronchodilator therapy, which is obviously just part of our tiny initial discussion here, and they learn the basics of exercise, which is to control breathlessness, not to push themselves to the limit, and they follow a plan that's either BC Lung Foundation webinar or the BC Lung Foundation printed information that you can get off the internet, or you look at something like the Living Well with COPD exercise program, you can attain tremendous benefit on your own. There's ample evidence to show that if a person exercises on their own, they're motivated, they understand how to do it, that they can do remarkably well. There's also evidence that a program in a rec center that's not as supervised, but you've still got somebody there to offer you encouragement, incentive, and guide you. That is excellent. And then, of course, the Cadillac or Mercedes or Audi, whatever your favorite car is, the rehab program that's run by kinesiologists or educators or whoever it might be, physiotherapists, they're totally supervised right from beginning to end. They're brilliant. The bottom line is each of those programs works effectively. One hasn't been shown to be better, but clearly the more severe the lung disease or the more comorbid conditions or the more breathless or anxious a person is, clearly the better they do with the supervised program. Don't let me steer you wrong. But what I'm saying is people can increase their fitness and can experience tremendous improvement on their own if they're stubborn and determined and they seek the information, and BC Lung Foundation is certainly a great place to start. So there's my rant. I wish I had something more favorable to say, but I don't.
All right.
But I'm gonna retire next year, so they can't fire me. And if they did, I hate to say that, but it's true.
All right. I think that is a good place for us to stop. Thank you so much to Mark for staying over time, addressing everyone's questions.